Assalamu alaikum. I would like to thank the organizers for the invitation. Also, I hope that all of you are enjoying the 21st annual conference of Pakistan Society of Hepatology. Inshallah, I will be there in person next year. The topic today is Budd-Chiari syndrome. Although some of you may not have seen a case of Budd-Chiari syndrome, but this is still considered one of the causes of misdiagnosis. Therefore, my hope and goal is in the next 20 minutes to discuss about the diagnosis of Budd-Chiari syndrome, how the patients normally present, and then how do we manage these patients in a stepwise fashion. So Budd-Chiari syndrome is defined by obstruction of hepatic venous outflow, and it can be anywhere from the hepatic venules to large hepatic veins to the IVC. It is overall rare, and depending on different studies, it can be seen in 0.2 to 2 per million population. When we think about Budd-Chiari syndrome, which is the obstruction of any portion of hepatic venous outflow, we divide into two different aspects. One is the primary Budd-Chiari syndrome, which is basically issues with the endoluminal or inside the lumen of hepatic vein issues. And the common causes are either you have a thrombosis of the hepatic vein or you form these webs called spider webs in the hepatic vein. And this is in the Western world, we normally see typically pure hepatic vein thrombosis as the most common cause. In Asia, the cases that we have seen or heard or read about are pure IVC, or what we call a combined IVC and hepatic vein block. Although the demographics have been changing and there is also more hepatic vein thrombosis reports are coming from Asia. Now, there's a secondary Budd-Chiari syndrome, which is obviously by the name, it means that there is a problem outside the venous system. And this is seen in if you have an invasive or extrinsic compression. And most common causes that we see are malignant invasion, like hepatocellular cancer or other cancer that is compressing or invading the hepatic venous system. And they can also present the same way as primary Budd-Chiari syndrome. The other causes that we have seen large cysts, tumor, or abscesses. Now, this is a nice diagram which actually shows a different form of Budd-Chiari syndrome, and these are the hepatic veins. And either you can have a web, you can have a stenosis of one of the branches of hepatic vein, you have a thrombus of the hepatic vein, or the IVC. You can also see it, as most of you are aware that when we see not only cirrhosis, but especially in Budd-Chiari syndrome, you do see caudate lobe hypertrophy because of the blood supply of the caudate lobe, which also get the blood supply from the other part of the liver through the caudate vein. Some of the pathophysiological consequences of the obstruction then ultimately include sinusoidal congestion, then it causes ischemia of the liver and ultimately hepatic necrosis. It does depend upon the presentation and about the timing of when the injury happened, like how quickly the thrombosis or other injury happened. And that's why when we talk about different presentation versus including acute liver failure versus chronic, the presentation can vary, and it is based upon how quickly the obstruction has developed. The diagnosis does require an unequivocal and radiological confirmation of obstruction of hepatic venous outflow, and we'll talk about some of the imaging technology, but ultrasound is with Doppler as one of the key and the first step in the diagnosis. In the earlier era, without the treatment, this carries a very high mortality of 90% in 3 years. However, recent studies, especially a largest prospective cohort study from Europe with this registry of NV, reported 5-year survival of 85% in the 157 patients. And this is likely because of earlier diagnosis, and now we know better understanding about the management and starting anticoagulation early on. If you look at further in the pathophysiology, again, most of the symptoms that we see or even any of the signs are because of hepatic venous outflow obstruction. So when your hepatic veins are obstructed, it causes increased sinusoidal and portal pressure, which can ultimately cause extravasation of fluid from the sinusoid. And one of the most common presentation in patients with Budd-Chiari syndrome is development of ascites. However, with venous stasis and congestion, it causes more hypoxia or ischemic liver injury, ultimately cause hepatocyte necrosis. Started with centrilobular because of the vein. So most of the heart injuries or other form start in the centrilobular, but ultimately it causes lobular collapse. And if this hepatic venous outflow obstruction and congestion and venous stasis versus over a long period of time for years, it ultimately starts causing fibrosis. And this is also, in addition to developing cirrhosis, also form nodular regenerative hyperplasia. So these patients with Budd-Chiari syndrome have these regenerative nodule that is pretty typically especially in chronic Budd-Chiari syndrome. And again, if the congestion and hepatocellular necrosis happen very suddenly, these patients can also present with acute liver failure. If you look at the demographic profile, there are, as I mentioned earlier, there are two main types. One is this present with more IVC obstruction or inferior vena cava obstruction, which is seen more in the east rather than west. And the common etiology is a membrane formation or membranous obstruction. And this presentation in Asia, which is mostly seen, is mostly chronic, which is like in 75 to 80%, more in males. Patients have ankle edema, and the ascites is present, but most of the studies say that, moderate ascites, and you'll see pretty impressive collateral in the abdominal vein because it develops slowly or chronically, so you have time to develop collaterals. And you do have hepatomegaly, and also because of the chronic nature, as I mentioned, they have cirrhosis of the liver. And as compared to the other form, the prognosis is good. And in Asia or in the East, this has typical association with pregnancy and infection. As compared to hepatic vein obstruction, which is mostly seen in the West, and the most common etiology is having an underlying hypercoagulable state. And that is, we'll talk more about the risk of thrombosis or hypercoagulable state. And this, as compared to IVC obstruction or mostly in are mostly acute, and majority of cases, like 60 to 85% present in less than 6 months, seen mostly in female as compared to male. We don't see ankle edema, but massive ascites. Since it happens so acutely, your body didn't have time to form collaterals. So there is no collaterals that we can see. And this is a classic presentation, massive tender hepatomegaly with ascites. And whenever in our fellows who are or our trainees, this is whenever it comes in exam questions that, any a female, a classic example is like, tender hepatomegaly with massive ascites. So they wanted you to think about Budd-Chiari syndrome. Also, the prognosis is poor or worse than IVC obstruction, and typical association, as we talked about with this hypercoagulable state, is oral contraceptive or underlying myeloproliferative disorders. So majority of patients with Budd-Chiari syndrome, especially in the West, has underlying thrombotic or which is greater than 80%. Therefore, even if you diagnose someone with Budd-Chiari syndrome, the one thing is for sure is that every patient should undergo routine screening for thrombotic risk factors. So we do have our hematology or just send all the thrombotic, or thrombophilia workup. And the JAK2 is most commonly detected abnormality that we see, which can be seen in up to 75% of the cases. Although there can be multiple causes in the same patient, and this just gives you an idea based on different studies that myeloproliferative disorder can be seen in about 40 to 50%, antiphospholipid factor 5, paroxysmal nocturnal hemoglobinuria, factor 2, protein C, so different mutation or deficiencies. Also, recent pregnancy can be seen up to 6 to 12, and all contraceptive use, especially in the West, and that's the one question we ask our patients very commonly. Now, the uncommon causes, and this is mostly when we talk about secondary Budd-Chiari syndrome. So if you're a patient with hepatocellular cancer or any big cancer present with tender hepatomegaly and ascites, they can look like Budd-Chiari syndrome, and they have the same pathophysiology. But also there are some other conditions like fungal infection with aspergillosis. You have inferior vena cava webs, which is seen in the East, trauma, inflammatory bowel disease, and some other causes, and dacarbazine therapy. And there may be cases that you would not have any underlying or which we call idiopathic causes. At the same time, there are some studies from France and Italy that they have not found an underlying thrombophilia or hypocoagulable in about 15 to 30% of the cases. So presentation can be very varied, and that's why you have to have an open mind, because although when we talk about this acute presentation with a board question like tender hepatomegaly and ascites, but this can present with any form. And as I mentioned, the presentation will be dependent upon the extent of thrombosis or hepatic vein obstruction and how rapidly the hepatic vein been occluded. And that's why, acute to subacute and chronic forms can present differently. However, ascites is one of the most common sign that are a symptom of abdominal distension in patient hepatomegaly. Although, again, you see that it's only seen in 2/3 of the patient and abdominal pain. And so these are some of the common presenting. It can be often mistaken, especially for a viral hepatitis, acute cholecystitis, and a lot of patients, based on their presentation, because right upper quadrant pain and elevated liver enzyme, they take into the operating room for possible cholecystitis. Now, it is important to differentiate some of the injuries that happen in the heart. So because it's not in hepatic vein now, and that is in the differential diagnosis, and that include tricuspid regurgitation. If you have constrictive pericarditis or right atrial myxoma, these can similarly present like tender hepatomegaly and ascites, and but these are not Budd-Chiari syndrome. This is the differential diagnosis, and the common. If you have some concern on physical examination, the best is to get an echocardiogram to look for cardiac causes. When we look at the liver enzyme, it can, like even in the acute form or fulminant form, that it can be liver enzymes are elevated. And then occasionally we have seen alkaline phosphatase and bilirubin to a variable extent. Now, it is also important when we talk about portal hypertension as a cause of ascites, we know that patients with portal hypertension have elevated or high serum ascites to albumin gradient. And as similar to this scenario that in Budd-Chiari syndrome, the high serum ascites to albumin gradient, but this is a different thing from patient with cirrhosis or other cause of portal hypertension, that their ascites protein is high, which is greater than 2.5. That's another board question at least, or that is one of the questions we do or ask our trainees. So that is an important point to notice. Now, when we also look at the different presentation, we hear a lot about acute liver failure as a presentation, but it's overall rare of about 7%. And this is typically the hepatic vein obstruction of symptoms are less than 2 months. And these patients do present with hepatic encephalopathy, as that's in the definition of acute liver failure. Now, acute, which we call, if it's the obstruction of presentation is up to 6 months, which is a classic presentation of the board question, sudden tense ascites, tender abdomen, hepatomegaly, no collateral, and liver enzymes are greater than 5 times upper limit of normal. And these patients, if you need histology, although don't need it for the diagnosis, there would be no cirrhosis. And subacute form, which is the most common presentation, normally are within injury or symptoms are 6 months to years. And they do have ascites, hepatic and portal collaterals are seen. Liver enzymes are mildly elevated. And then on biopsies, you have mild necrosis, but no cirrhosis, as compared to chronic form, which takes years and just like any form. And most of the time, these patients present with chronic liver disease like ascites and varices and hepatic encephalopathy. And it's important, if someone we label as cryptogenic cirrhosis, it's important to make sure that we have ruled out Budd-Chiari syndrome, and this patient obviously has advanced fibrosis or cirrhosis. Now for the diagnosis, the best and the initial test of choice is a good quality Doppler ultrasound of the liver. But obviously your technician and radiologist need to know that what you're looking for, and they need to be experienced to make that diagnosis. However, in experienced hand, it's an excellent sensitivity and specificity, and that's what they can easily our radiologists can see it. And here you can see that there is no flow in the hepatic vein, and they're different, but it can be different presentation. The contrast enhanced CT and MRI can also be very helpful. This is a CT scan where you see the hepatic veins are obstructed, and you can have like other like caudate road hypertrophy and different presentation. Also for the diagnosed Budd-Chiari syndrome, on the hepatic venography, when the IR interventional radiologists look at it, this classic pattern of spider web. And then it is necessary when you have a very strong clinical suspicion, right, of Budd-Chiari syndrome, but the ultrasound is negative or the scans have been negative or non-invasive imaging, we do have interventional radiology does an hepatic venogram to confirm the diagnosis or rule out the diagnosis of Budd-Chiari syndrome. Now, MRIs has been used more and more for the diagnosis of Budd-Chiari syndrome. If the ultrasound, you need more imaging. And this is like, you can see a big caudate lobe hypertrophy here. You have this hepatic veins that you can comes as like hepatic hypointense fibrous cords, and you can have these macro nodules here. So they can be seen multiple different findings, and a good radiologist can easily tells us all the finding that we can see in Budd-Chiari syndrome and also make the diagnosis. Other findings that we have seen, and when we talk about the HCC screening in patients with Budd-Chiari syndrome, it is common, as I mentioned about, because of congestion and the blood supply, it's not uncommon for these patients to have large nodules. Most of these nodules are benign, and they do mimic or looks like focal nodular hyperplasia. And on imaging and also histological examination, although they are patients with cirrhosis, right, and then also with membranous obstruction, have been associated with development of hepatocellular cancer. So any patient with cirrhosis, we do recommend surveillance for hepatocellular cancer. This is, if you make the gold standard diagnosis is venography or interventional radiology, looking actually of the hepatic vein, but only we do it in cases where other testing are negative, meaning ultrasound or MRIs, and you still have a high clinical suspicion. So this is a good example in this section. This is a normal venography. You can see a classic pattern of all the veins, but then this is sometime I've seen in the board question in the United States that it's a rich collateral between hepatic vein. It's called and looks like a spider web, and this is very classic for Budd-Chiari syndrome. Liver biopsy is not required for the diagnosis, and I hardly have it. There are only few scenarios. Also, the few things to notice is that it can be the finding on the biopsy can be very patchy on vascular involvement. And you all are aware of it. This is a normal liver biopsy. You have this portal tract, a bile duct, you have sinusoid and central vein. And that's where the sinusoids, as again, the blood is coming back. So sinusoid and central vein where you see a lot of injuries. And then here on this biopsy that we see, you can see centrilobular, which is like hepatic vein. So there's a lot of necrosis and sinusoids are dilated. So if you see the sinusoids here, these are normal. And then you can see the sinusoids who are dilated around it. So this is some of the, but this is not like a diagnosis. This can be seen similarly in heart failure or other heart conditions that we have mentioned before. Now, lastly, the management. So it is important to understand that there is a stepwise fashion that how we recommend management of Budd-Chiari syndrome. And the normally steps that we normally take in majority of patients, there are always exceptions, especially if someone has an acute liver failure. The first step in all the patients is anticoagulation, whether it's low molecular weight heparin or coumadin or other compound to it. And the goal or aim of the anticoagulation is, if it's acute, you can recanalize, but at the same time, in chronic, you prevent the thrombosis progression. If that doesn't work or you have progression, the second step is percutaneous angioplasty, which is like opening the hepatic vein, and this is to maintain or restore the outflow. Then you have tips that you can actually, is the next step, which control the portal hypertension decompensation. And if all these fails, the next step becomes acute. The next step is basically liver transplantation. This is a nice article from New England Medical Journal and talk about the different step. Again, we have thrombolytics or anticoagulation. We have angioplasty with and without stenting. However, it works better for the webs or stenosis, not for thrombosis. And most of the time, because of high rate of restoners, shunt occlusion, tips can be bridged to transplantation versus management. Surgical shunts can still be used in certain category, but with the invention of tips, I have not seen recently people getting surgical shunt or liver transplantation. Now with the new covered stent that we have, the patency of these stents are significant and tips have been more. And so if the primary patency now is like 76% with the covered stent, and secondary patency are 99. So these patients are doing really well after the stent, but they would always require anticoagulation. So this is from the EASL guideline. Most of the data stepwise approach is based on retrospective cohort and prospective series of patients. There is no randomized control. They're not that common of a condition. Again, same thing, medical management, starting with anticoagulation, angioplasty, stenting or thrombosis tips, and then liver transplantation. The medical management that all patients, as soon as the diagnosis or suspicion of the diagnosis, we start anticoagulation, right? We do talk about bleeding complication. There's been studies done even in patients with varices, the risk of bleeding is lower. However, in a chronic form, that if you see varices, it's recommended to eradicate the varices and then continue the anticoagulation. It is also very important medically that, as I mentioned, that all the patients, especially when we talk about the West, need to get the workup for hypercoagulable workup or thrombophilia workup. And then you treat the underlying myeloproliferative disorder present with hydroxyurea, other treatment. So we work hand in hand with the hematologist, right? And again, the goal of the anticoagulant is to reduce the clot extension and also prevent new thrombotic episodes. So anticoagulation is the cornerstone in the management of Budd-Chiari syndrome. Now, some people do ask with the newer anticoagulant, the direct agent oral anticoagulant, there's case series and small studies have been done and that seem to be safe and effective. So a lot of time we have used coumadin, but these are newer agent. And since we have some reversal agent in the US, we are using more and more with the help of our hematologists. The second step in the management is angioplasty, stenting, and thrombosis. It has to be an experienced hand because in an experienced hand, they can correct the hepatic venous outflow obstruction. But the thrombolysis is limited. Most of the time we use like angioplasty and stenting. And this is a definitive therapy for patients with webs or other things, although less likely, as I mentioned, we mostly seen in the West is thrombosis. So this is only can be offered in 10% of the Western patient. Recently, I had a few patients with Saudi Arabia who were diagnosed with just cryptogenic cirrhosis. And when we saw them, they had this classic presentation and angiography did show that then after the stent placement, their symptom of ascites actually resolved. Now, patient non-responding to medical therapy should progress to the next therapeutic step. So if you start anticoagulation and then it continues to progress, then you go to the step, not as the first step. And this is the EASL guidelines that patients who are non-responsive to medical should go to the next step. But we also have to closely monitor these patients, especially they're present and acutely. And TIPS is the standard shunt procedure. However, if the TIPS is not available, then surgical shunt is surgical shunts are good alternate option. Lastly, liver transplantation. Liver transplantation is associated with similar survival to the patient who are initially treated with TIPS. And there are some patients with chronic liver disease, cirrhosis, or portal hypertension may benefit from liver transplant without prior TIPS. But you don't have a way to identify it. There are some like algorithm like Budd-Chiari syndrome, like ranking scores, but nothing really for, I would say that it's clinically just based on the symptoms. MEL score, I still think is a good way, although a lot of these patients are anticoagulation. And then one of the largest series that overall 5-year survival after TIPS placement was 84%, which is similar to orthotopic liver transplantation. And transplant-free survival at 1 or 5 years were 88 to 78%. So I normally, if I had a lot of patients who have TIPS done for like 10, 15 years and doing well and going on with their normal life. So liver transplant is only if your shunt has failed or TIPS has failed. So this is because they do really well with the TIPS procedure. So liver transplantation is the last therapeutic step. One thing, because the patient with Budd-Chiari can recur even after liver transplantation. And therefore, after liver transplantation, these patients with Budd-Chiari need to start on anticoagulation and maintain in lifelong, right? So that is one of the mistakes I have seen in one patient that they did not start with anticoagulation, thought that they treated the Budd-Chiari syndrome. So that's incorrect, right? So these patients need to be on anticoagulation after transplantation. So these are some of the data. This is an older study, but they looked at the UNOS data set with 510 patients for liver transplantation from 1987 to 2006. And then 3-year cutoff survival was 80% and 3-year patient survival was 85%. So these patients, if they need a liver transplant, also have good survival. Lastly, few points I wanted to make sure that we do understand that these patients does have risk of benign regenerative nodule, especially in chronic Budd-Chiari syndrome at 30 to 60%. And it's sometimes very, very, very hard for the radiologist to differentiate whether these nodules are benign or sometimes the HCC. But most of these regenerative nodules are small, less than 3 to 4 centimeter multiple. They can be more than 10. And sometimes they are hypervascular, so even worse, but they may even have washout. So it will be very difficult to differentiate from hepatocellular cancer. At the same time, in patients with chronic Budd-Chiari syndrome, they can develop hepatocellular cancer. And then there is one study suggests that 5% cumulative incidence is 5-year in a large cohort study. So in any patient with chronic Budd-Chiari syndrome, we do recommend surveillance with hepatocellular cancer, just like in patients with cirrhosis. Now, in America, since Budd-Chiari syndrome is seen more in female, that, there is a young female, they always have discussion whether they can get pregnant. So there are excellent maternal outcome, provided disease is well controlled. However, as any cirrhosis and portal hypertension, any woman who wants to become pregnant, they need to be screened for esophageal varices. Vaginal delivery is preferred mode of delivery. You don't have to do C-section. Although the fetal outcome may be a little bit less favorable, but if you have a pregnancy reach at 20 weeks, they have an acceptable prognosis. Vitamin K antagonist is associated with high risk of miscarriage. So therefore, it's important if you're a patient who is interested, because of the congenital malformation, you switch these patients to low molecular weight heparin if they are interested in becoming pregnant. Now, in summary, as I mentioned, because of hepatic vein, where the obstruction is, how quickly it happened, these patients can present at very different, clinical scenarios, their different presentation. So Budd-Chiari syndrome should be suspected in any patient with acute or chronic liver disease, especially when its etiology is unknown or you have an underlying prothrombotic condition present. Diagnosis require unequivocal radiological confirmation of hepatic venous outflow. Underlying disease should be diagnosed and treated very quickly. And most recommendations based on the expert opinion and some of the studies that support the gradual escalation of management from least invasive, basically anticoagulation starting, and then if you need if there's a web or some other membranous, you start with just angioplasty and stent, then going for the tips and ultimately liver transplantation. So it's not that these cases are very rare in Pakistan, but I think the diagnosis may not be present. So you need to have a very high index of suspicion. Although TIPS is not that commonly available, but this is one of the indications that if you have a patient and as it's not responding to anticoagulation angioplasty, these patients need to be considered TIPS. And then then you can avoid a liver transplantation in a lot of these patients. So this is the end of my discussion, and hopefully I will be present to answer any questions at the time. Thank you.